Welcome back everyone to chapter 20. In this chapter we're going to talk about the diseases that affect the eyes, ears, nose, and throat. This particular chapter is broken up into two parts. So we'll have a part 1 and a part 2. Part 1 that we're going to start on right now is going to be roughly just a little north of about 60 slides. And then when we come back for part 2, that one is I think somewhere around 54, 55 slides, something along those lines. And with that, we'll go ahead and get started. So, as paramedics, you'll often respond to calls that involve the eye, ear, nose, and throat, and issues that may arise from those. Now remember, in this one, we're not necessarily talking about the trauma-related things. We're mainly talking about diseases and medical-related things. But there are a lot of calls that are related to trauma when it comes to these. So we'll try to set those aside and mainly focus on the medical side of things when in this chapter when we're talking about the eyes, ears, nose, and throat. So understanding some common EENT conditions helps you assess the patient quickly and accurately. In some situations, the patient may need to be transported to an emergency department that has a specialist like an eye doctor or an ear, nose, and throat doctor for further and more definitive care. So we'll start our discussion. We'll lead off talking about the eye, and then we'll work our way kind of down a little bit, kind of down the head, and talk about these things. So remember, the eye connects to the brain through two main nerves: the oculomotor nerve, or the cranial nerve number 3. And this nerve works with the trochlear, or the 4th cranial nerve, and the abducens, the 5th cranial nerve, to control the muscles that move the eye up, the eyeballs and the upper eyelids. It also carries parasympathetic fibers that control things like pupil constriction and focusing of the lens that we don't have control of. The other nerve is the cranial nerve number 2, or the optic nerve. It's responsible for the sense of vision. So those two main nerves. This slide is just an overview of the various parts of the eye. For a more in-depth review and study of the eye and its parts and how it functions, I would ask you to refer back to your A&P text, because that can get into a fairly in-depth discussion. And you're going to notice that, in the review of these parts of the, eyes, ears, nose, and throat, we're not going to review these fully and in-depthly and how each part of those function and work. We're just going to kind of provide a little structural, here's the parts. Hopefully, you need to remember how these function, what normal function is, and then we're going to mainly focus on the dysfunction of those things and the issues that can arise from that. So, when we talk about a patient assessment, and this has been true through every single one of these chapters that you guys have endured so far, is we always want to make sure that the scene is safe, not only for ourselves, but for our patient and for the bystanders and everyone there. Our primary goal is to make sure, well, maybe not primary, but a big part of our goal is to make sure that everybody is safe on the scene. Keeping the patient calm in order to avoid making things worse is also helpful, and we'll talk about that a little more specifically, but this is kind of a general thing that we want to do for all of our patients, kind of provide that calming atmosphere. Get our general impression, start to get things organized in our head, and we'll do that by looking for the environmental clues around us, and maybe even just a quick estimate of age and sex and those kinds of things, and their level of distress that they're feeling. Take a good look at their airway and breathing and make sure that that's okay and that's not an issue. Some of the things that we'll talk about, will involve laryngeal issues. So there can be some problems with breathing, and there can be the potential for airway compromise. And we want to provide early transport in those situations where the patients need that. So don't hesitate if you feel like you need to get on the move, because it can improve outcomes. When we're talking about eyes, we want to prevent any extra damage caused by sympathetic movement. So typically we'll cover both eyes when we're managing one eye issue or especially injury. Pain management is important. We may need to consider administering something appropriate as long as that falls within our scope and within our protocols to be able to do something. If not, we might be able to reach out to medical control to see if they will give us some orders to maybe give something as well. Cardiac monitoring is pretty standard with most patients, but realize that when we're talking about the eye and ocular pressure, how it can stimulate a response from the vagus nerve, cause some things to kind of happen or slow down, cause some bradycardia. Also, medications like eye drops can affect blood pressure. So if they've overdone it with their eye drops or something along those lines, it can either raise or lower their blood pressure if they've overdropped their eyes. Of course, don't forget to provide some emotional support and keep the patient as calm as possible and keep them relaxed, until we get them where they need to be. As usual, we're going to start by obtaining a chief complaint, using OPQRST as a way to guide our questioning. There are some other specific things we probably should ask, things such as what symptoms are you currently experiencing? Are both eyes affected, or is it just one eye? Are there any known eye conditions or diseases that you have, that the patient has? Symptoms that may indicate a serious ocular condition are things such as vision loss, especially that doesn't improve when the patient blinks. So, vision loss doesn't necessarily mean that they can't see anything and it's just black. It could mean that things are just so blurry and out of focus that they can't see anything. If blinking doesn't improve that, we need to make note of that. If they're seeing double vision, or if they're experiencing severe eye pain. And of course, if there's a foreign body sensation in the eye, it doesn't necessarily mean that there's been trauma to the eye, from an outside source, but there could be something medically going on in that eye that makes it feel like, or give them the sensation that they have something trapped in their eye. So when looking at someone's eye, here's some things we want to look for when we do that. Is the eye sore or tender to the touch, or the tissue surrounding the eye? Is it puffy or bigger than normal? Does it move normally, or does it kind of seem to be stuck or moving in some kind of weird way? Can they feel things okay around their eyes? Is there any numbness or tingling? Does the color look right? Paleness or blueness or any other discoloration? Does it look misshapen or out of place? Is their vision okay? Is it blurry? Is it doubled? Or are they seeing spots or anything like that that's out of the ordinary for them? We also need to make sure that nothing around the eye is blocking their breathing. Although that's much less common with eye injuries, it's still something we need to consider, that there may be something bigger picture going on with the face that may ultimately affect breathing. So think ahead. And think about how this particular situation may be affecting something long term. Basically, we're just checking to make sure that the eye looks and feels normal, and if the person can see properly. It's pretty simple as that. Assess the following visible ocular structures as best you can, such as the orbital rim. Check for bruising or swelling, or even cuts or lacerations or tenderness around the eye area. Take a look at the eyelids for bruising or swelling or any cuts, or in any unusual signs like abnormalities in shape or position. Look at the corneas. Check for any foreign bodies that may be stuck on the surface of the eye, or any obvious signs of injury or swelling or anything like that may be going on there. Look for signs of pus, redness, or inflammation, or foreign bodies that could be irritating the eye in the conjunctiva of the eye and the areas surrounding the eye that make direct contact with the eye. Look for any issues there that may be causing the problem. Check for redness of the globes, unusual pigmentation or cuts to the eye. And look at the eye surface itself for any growths or discoloration, or if there's a noticeable difference between the two eyes that's unusual for that patient. Of Of course, when you assess the pupils, remember you're going to use that acronym PERLA, and what you're looking for there are the pupils equal, round, and reactive to light, and when they focus on something, or when they focus on something close. So that's a great way to determine how well the eyes are functioning, and look at nerve reactions within the eye as well. It's also something that we use for other neurological things that we're looking at. So it's a very common thing that we'll use when we're assessing issues with the eye. When assessing ocular function, perform the following tests. We want to test their visual acuity. So we want to see if the patient has the ability to see both large and small letters, and make sure to test each eye separately and document the results accordingly. Test their peripheral vision. Are they able to recognize an object entering the far edges of the field of vision? And at what point can they recognize that particular object? And then you want to check the mobility of the eye. Check if the patient can move their eyes in all directions. Look for signs of paralysis of gaze or discoordination between the eyes, which could indicate a disconjugate gaze, which is where both eyes don't move together. So the eyes are not moving the way that we would normally expect them to move. But also be aware you need to make sure that this is an unusual thing for that particular patient as well. It could be a normal thing, so make sure that you ask the right questions. The patient may experience adverse effects if they use more than one eye medication at the same time, kind of as I mentioned earlier. Maybe they're mixing their medications and they shouldn't be mixing them, or they use too much, which can lead to some of those side effects. Ask them how they administered any medications. It's generally recommended to wait 5 minutes between the first and second drop if using multiple eye medications, and some patients don't necessarily understand that. But realize that the 5-minute rule may not apply in emergency situations where faster administration may be needed, so it can be confusing for patients. Eye drops are commonly used for things like conjunctivitis, red, dry, itchy eyes, sometimes pain relief. It is a form of glaucoma management. It can be used to aid recovery after an eye surgery. It's used for treating infections of the eye like herpes simplex, corneal abrasions, and it may just be used for lubricating or promoting tear production to keep the eye moist. There's a lot of different types of drops that are out there that are used for multiple purposes to treat conditions with the eye. Some mixing of those can be problematic, so especially if they're going to more than one physician and one doesn't know what they're already on, so we can wind up with problems. Eye drops and lubricants can be applied by gently squeezing the lower eyelid to create a small pouch for the drops, and placing the medication directly into the lower eyelid. Of course, then you want to have the patient close their eyes, roll them around to help the medication spread, and then you may need to apply a little bit of gentle pressure to the corner of the eyes to prevent the medication from leaking out the sides. Always ask before you give a medication what that patient has already taken. This helps to avoid any overuse or potential interactions with the different medications that are being administered. Irrigation may be necessary for chemical and thermal burns. Of course, we're going to use sterile or isotonic saline solution to irrigate the eye. Always flush from the inside corner of the eye towards the outside to push the chemical further, to avoid pushing the chemical further into the eye and more pushing it away. Eye injury should always be seen in the emergency department, so any injury to the eye, chemical, thermal, anything like that, should be seen in the emergency department, no matter how minor it might be, because they may still require some sort of specialized care. Eye injuries can easily become irreversible and permanent, so if not treated properly, they can lead to permanent damage or loss of vision in the affected eye. If they're wearing contact lenses, The only reason that we're going to remove contact lenses in the pre-hospital setting is for a chemical burn to the eye. So we want to take those contact lenses out if there's a potential for chemicals being stuck in, on, or around and under that contact lens. There's different procedures that we can use. Sometimes the patient can help us do that. It says to use a small suction cup, moistening the end with saline to lift the lens off the eye. We may or may not have that available in the pre-hospital setting. Sometimes we can flush that with some saline and then have the patient help us get a hold of that to remove the eye, to remove the contact lens. They're going to be a little more comfortable with, touching their eye or removing a lens or those kinds of things than we're going to be, because they do that pretty routinely. They're going to be pretty comfortable with that. Soft lenses are a little different. Put a couple of drops of saline in the eye to get the lens to kind of move around, and then gently pinch the lens between your gloved thumb and index finger, then carefully lift it off the eye. Soft lenses are pretty easy to get off the eye. Always make sure you let the ER staff know if the patient was wearing contact lenses, because this will help them prepare for proper care and avoid complications that may be related to the lenses as well, so they have a better understanding of the whole picture of everything. Some patients may even have a prosthetic or artificial eye. We probably would suspect this if the eye doesn't respond to light or it doesn't move in sync with the opposite eye. Sometimes some of them are very, very good and the eye looks perfectly normal, but others may not look quite the same as their regular eye, their real eye. If the patient recommends or mentions that they have an artificial eye, it's pretty easy. But if you're unsure, you just simply ask, about that particular eye, and then they'll typically tell you. It's usually when you start looking around at their eyes, they are pretty quick to tell you, oh, hey, my right one's, prosthetic, so it's not real. So how do we assess and manage some specific conditions of the eye? Well, the first one we're going to look at is conjunctivitis, of course, also known as pink eye. It's pretty common. What happens is the conjunctiva, the area around the eye, becomes inflamed and red. Usually starts in one eye and then spreads to the other. It's typically caused by any number of things, but typically we see bacteria, viruses, allergies, chemicals, foreign bodies, those kinds of things. The one where everybody's always worried about is the viral or bacterial conjunctivitis. Viral is usually linked to an upper respiratory virus, whereas bacterial is caused by bacterial infections. Both of these are highly contagious and easily spread. Of course, viral has to run its course. Bacterial is going to have some antibiotics. And then it could even be allergic conjunctivitis that's triggered by pollens. Chemical conjunctivitis, as you can imagine, is maybe from air pollution or even things like chlorine in swimming pools. Those usually pass themselves, once the irritant is removed. And then, of course, a foreign body can cause the eye to start producing, can cause conjunctivitis. And of course, the eye will try to produce tears to try to flush out whatever that object is as best that it can. So we'll do our general assessment on the patient's vision to understand the severity of the situation that we're dealing with. Viral conjunctivitis is usually going to resolve on its own, but could need some kind of symptomatic relief to help. There may be some eye drops or that kind of thing. Bacterial, however, requires topical antibiotics to treat the infection. Allergic conjunctivitis may require the use of steroids, antihistamines, and even a topical steroid placed on the eye to help get everything back under control. So, inflammation of the eyelid. Now we'll step back from the eye. We'll take a look at inflammation of the eyelid. This is where the eyelid has that protective film of oil glands and oil ducts that help keep the eye lubricated. Chalazion is a small, swollen bump. I'm probably not pronouncing that correctly, so I'll butcher some of these words. Chalazion is a small, swollen or bump or pustule on the external eyelid caused by a blockage or swelling of one of those oil glands. We've probably all seen them, a little bump. It kind of looks like a pimple on the eyelid. A hordeolum is an infection of an oil gland that creates a red tender bump on the eyelid or the eyelid margin. It's commonly known as a stye, which is much easier to pronounce than hordeolum, which like I say, I don't know if I'm even pronouncing it correctly. That's the best translation that I can do on that. So forgive me if I'm butchering it, but it's much easier just to call a stye. These two look similar in some ways, but if you look at the picture on your slide, the top one, the chalazion, is more of a bump, kind of under the eyelid, whereas the other one is more pimple-like. The stye is more pimple-like. So, of course, we're going to do our regular assessment on the patient and consider transport if necessary. I can't imagine getting too many calls for this, but they'll typically be instructed to apply a warm compress for 5 to 10 minutes several times a day to help the swelling and discomfort. There may be some topical or oral antibiotics that are prescribed for the condition if there's an infection, especially the case with, if it's a stye. That might be the route that's presented. So, but hopefully we're not getting too many calls like this that it's going to be much of an issue. Glaucoma, of course, is a group of conditions that causes increased interocular pressure, which can damage the optic nerve. We very well may get calls for this because of the pain that it causes. It's one of the leading causes of blindness worldwide. So if you remember, the aqueous humor is the clear watery fluid that fills the eye's interior chamber. Of course, it's designed to maintain that ocular pressure and provide the nutrients to the inner eye surface. And it also helps kind of bend the light during the vision process in order for us to see properly. It circulates through the pupil and drains into the venous system via the cranial cilium. There are several types of glaucoma. There's open angle glaucoma. It's where that fluid in the eye drains too slowly and the pressure begins to build up and it damages the optic nerve. The optic nerve inside the eye is very sensitive to these pressures, and these changes in pressures begin to damage that nerve. This is also the most common type of glaucoma, which is open angle. There's normal tension glaucoma, which can cause vision changes even without the increase in ocular pressure. So this one's a little bit different in the way that it works. And then, of course, there's narrow angle glaucoma. It's where the fluid doesn't drain properly due to a narrowing of the drainage channel. So the way that it drains in the back. This causes pressure to build up in the posterior chamber and pushes the lens forward. The lens then pushes the iris into the drainage channel, and then ultimately it completely blocks the drainage out of the eye. Most of these conditions are not easily treated, if treated at all, so glaucoma is generally degenerative. Secondary glaucoma results from conditions that damage the eye's drainage channel, such as diabetes, eye injuries, leukemia, some sickle cell anemia disorders. Certain types of arthritis and even cataracts can cause secondary glaucoma. Glaucoma is becomes more common as people age. It's typically managed with eye drops to reduce that interocular pressure, but once again, the disease can progress to the point that those things begin to not work as effectively. What a patient will typically complain of is a loss of the field of vision, particularly in their peripheral vision. They wind up with this progressive tunnel vision that can lead to complete vision loss. Patients with an acute attack of narrow angle glaucoma may report severe eye pain, headache, photophobia, nausea, vomiting, maybe blurred vision or halos around light. This would be pretty common that we would get a call for this. The cornea, when you do your assessment, may appear to be cloudy, and the pupils may have irregular margins, often being fixed in the mid position and dilated. Acute narrow angle glaucoma is a medical emergency that requires immediate attention, or they may lose complete vision in the eye. So we want to rule out trauma or any kind of physical injury as a potential cause. So you'll always perform that general eye assessment to check out any other potential causes. We see these couple of devices here on your screen. Commonly, in the emergency room or in physicians' offices. An ophthalmoscope is used to examine the structures of the eye, especially the retina and the optic nerve. And then we have an otoscope that's used to look at the internal parts of the ear canal and the tympanic membrane or eardrum. These devices require a certain amount of specialized training, so we rarely see them being used by paramedics in the field. So they don't have much of a place there, but you just need to be familiar with the devices that are needed to get a really good look at someone's eyes or ears. So a central retinal arterial occlusion occurs when the blood supply to the retina is blocked due to a clot or embolus, similar to a heart attack or a stroke. Only in the eyes where this happens. So the possible causes of this, of course, an embolus from the carotid artery, kind of coming up. Some kind of heart disease, some certain kinds of heart disease that involve the valves of the heart. Drug abuse, fatty embolisms, arterial spasms, maybe even from oral contraceptive use. This can actually lead to partial blindness, which may be temporary or permanent, depending on whether or not the ability to be able to reverse that is. Patients may experience sudden, painless loss of vision in one eye. The vision loss from the central retinal occlusion may progress within 30 to 120 minutes, so within 30 minutes to a couple of hours it may progress. It can occur while they're sleeping, making the condition much harder to detect immediately following when it happens, so it could be hours before it's actually detected. Immediate transport is critical if they have any hope of regaining their vision in that eye. Early treatment is essential to preserving that vision, and the treatment's probably going to be similar to many other clot-related treatments, through the use of some thrombolytic therapy. So iritis is the inflammation of the iris, or the colored part of the eye, also known as the anterior, I have no way I'm going to be able to say that, the anterior uveitis. It is the third leading preventable cause of blindness worldwide. Of course, I get the chapter with all the crazy words in it, of course. Iritis can be either acute or chronic. It's often caused by trauma or irritants to the eye, so it's not typically something that's a disease process, and it usually only affects one eye. It can be chronic from an autoimmune disorder, so a disease is not completely unheard of, but it's not the most common reason for it. But it can result from that, such as things like rheumatoid arthritis. Other causes can include, even irritable bowel syndrome and Crohn's disease can affect the iris of the eye. Infectious causes can be from like Lyme disease, tuberculosis, and even some sexually transmitted diseases. So hard as it is to believe, your eyes can be affected by other things going on in your body. Typically presents with redness around the iris, some cloudy vision, and an unusually shaped pupil. A thorough patient history is essential to help identify the potential causes. Acute iritis usually responds well to topical corticosteroids, but only if the cause is not fungal, viral, or bacterial. If it's one of those things, it'll be a different route. Making sure we get them to a trained specialist is the key. So getting them to an ophthalmologist. They may not be trained to specifically recognize this, so they should be. They typically are referred to an ocular immunologist. If left untreated, iritis can lead to permanent vision damage or disability. So prompt treatment is critical, and getting them to the right specialist is going to be essential in making sure they get the treatment they need. Papilledema is the swelling and inflammation of the optic nerve. Typically presents with headaches, nausea, which may or may not be accompanied by vomiting, temporary vision loss or a narrowing of the visual field, and a graying or dimming effect in the visual field is not uncommon either. So causes, it can be a variety of conditions, including an abscess, a tumor, an inner ear infection, a lung infection, maybe even a dental infection. Meningitis could, other causes could include things like meningitis, fever, severe hypertension, chronic high blood pressure, and even Guillain-Barré syndrome can all kind of be a cause of this. Diagnosing papilledema will be made by an ophthalmologist or a physician. It's not something we're going to be really capable of doing in the field. However, we can treat some of the symptoms, such as managing the pain or the nausea that they may be experiencing, and we can make sure that we take them to a facility that's capable of assessing them to the degree that they need assessed, so they can get the treatment started as early as possible. Of course, watching your ABCs, which we do with every patient, and assessing for those life threats and addressing them as immediately as possible. Analgesics or mild sedation may be needed to help manage the pain and discomfort associated with papilledema. Cellulitis of the orbit is often caused by Staphylococcus or Streptococcus bacterial infections. This is more common in children than adults. It's often also can be referred to preseptal cellulitis or eyelid cellulitis. Symptoms would include painful red or swollen eyelid, maybe fever, redness in the white part of the eye. There can be some predisposing risk factors associated with it, such as maybe insect bites, near or around the eye, maybe upper respiratory infections, and even trauma to the eye area. Similar to cellulitis that we might see in other areas of the body, we typically see some kind of predisposing infection or something kind of leading up to this that causes, the inflammation of the cells around the eye, especially the fatty cells. Orbital cellulitis is an infection within the eye socket itself. It's considered a true medical emergency due to the risks and complications associated with it. The main goal of treatment is to prevent the formation of an abscess, which can cause spot pressure on the eyes. If the abscess develops, it can put a lot of pressure on the eyeball itself. They may have a history of sinusitis or tooth infections, maybe even facial or middle ear infections. Trauma to the face and or eye area can be a risk factor as well. And of course, sinus infections kind of falls right in with sinusitis, but sinus infections too. Treatment in children typically calls for some IV antibiotics. However, adults are generally treated with some oral antibiotics. For management of these patients, we need to rule out any life threats and address any immediate concerns first. Get a good history to help kind of drive the treatment decisions that's going to be made by us and others. And of course, making sure we get them to a facility that's capable of treating them appropriately. Probably one of the more common things that we'll see, and that we may actually get called for from time to time, is a corneal abrasion or an ulcer. They are among the most common eye injuries seen in emergency departments. And of course, They can be caused by a few things, maybe even direct trauma to the eye, a foreign body getting something stuck in your eye. Contact lenses can actually cause these. And exposure to ultraviolet radiation such as sunburns, tanning beds, using welding equipment or cutting torches and those kinds of things can cause that as well. An ulcer can develop if an abrasion is not treated promptly. If left untreated, it can actually result in permanent vision loss, or even to the extreme, possibly even blindness. Symptoms of a corneal abrasion include, and the big thing that is common with these is pain with extraocular movement. So you don't move your eye, it's not painful, but when you move your eye, it's painful. We'll see some redness, potentially see some redness in the affected eye, excessive tearing or watering of the affected eye or eyes, the sensation of having something in your eye. It feels like they've got something caught in their eye, which can lead to further problems because they're trying to get that something out. The abrasion can actually cause some swelling of the eye itself, which can lead to blurred vision or even a loss of vision. They may have some light sensitivity or photophobia. And headache is often due to the eye strain, the discomfort of trying to strain through the eye problem of vision and scratchiness feeling of the eye, which can lead to a headache. So, of course, obviously we need to rule out any live threats and address any of those immediate concerns. But generally speaking, a corneal abrasion is not anything super serious, and it can be treated. But get a good history so we know what's going on, and take them somewhere that can treat them for their, for this type of an injury. Generally, most emergency rooms can do that. Most emergency room physicians are going to be pretty familiar with this because, as mentioned earlier, it is a pretty common thing that causes a visit to the emergency room. Okay, let's talk a little bit about the ears. The ears are the primary structures for hearing and balance. We're all very familiar with the fact that we use them to hear with, but they are critical for balance. So disorders and injuries to the ear can significantly impact a person's ability to communicate, react, and to maintain balance. So changes in air pressure can cause discomfort or pain in the ear. Tumors on cranial nerves can affect not just hearing, but also balance, facial sensation, eye movement, facial movement, taste, and even hearing itself. And of course, hearing loss in children can interfere with their ability to develop essential communication, language, and social skills. So recall that the ear is divided into three main parts. We have the external ear, you have the pinna, that's the fleshy part of that ear, then we have the external auditory canal, and the exterior portion of the tympanic membrane or eardrum wall. Those are actually situated inside the head. They are still considered external. Then we have the middle ear. It's the inner portion of the tympanic membrane, and the ossicles that are in that area as well. We can kind of see that. You can see, on that image right there where the middle ear is. And then the inner ear, we have the cochlear area of the ear, and we have the semicircular canals that connect to the nerves that go to the brain. So all of these components, or all of these parts of the ear, are essential for good hearing or good ear production. The internal part of that is actually where the balance occurs, the inner ear. So sound waves travel through the ear, and the inner ear structures convert these sound waves into nerve impulses that travel to the brain via the auditory nerve. The brain then processes these impulses and interprets them as sound. So, when we're assessing a patient with possible ear injuries, we should look to see if there are any foreign objects that are pushed into the auditory canal that can damage the eardrum. Of course, ear infections can cause the eardrums to blister and bleed, and inner ear infections may lead to pressure behind the eardrum, kind of pushing out from the inside. Blast pressure waves can cause the eardrum to burst and cause hearing issues. So take a look at the scene and ensure that there's no hazards for EMS personnel and their crews. As you're approaching the patient, approximate the age. Look for those environmental conditions that may have affected this, and kind of look to see if you can tell the degree of the distress that your patient is in. Observing whether or not your patient is wearing a hearing aid could be helpful as well, because this could further affect their ability to communicate with you if they already have an underlying hearing problem. And make sure that the airway is in good shape and that they're breathing well and their circulation is stable. Manage any of those immediate life threats first. Take a complete history so that we can try to understand the cause of what's going on here. Look in the ears, look in and around the ears for any fluid or drainage, blood or anything like that coming out of the ear, an excess buildup of earwax or cerumen, and for signs of infection or even swelling or around the ear or in the auditory canal. Have the patient rate their pain and use OPQRST to round out your history taking. Ask the patients about changes in hearing, if they experience any tinnitus, such as ringing, buzzing, or hissing in the ears, dizziness, and of course you want to inspect and palpate for wounds, swelling, look for drainage, look behind the ears for bruising behind the ears, known as a battle sign, that may be seen with some skull fractures, and it would be a very noteworthy sign if we've seen that on a patient. So let's look at some specific ear issues. One of them that's actually more common than people realize is when they have the cerumen or earwax. It's that yellowish, oily substance found in the inner ear canal, becomes impacted in the ear. What this stuff actually does, it helps to prevent the dirt and water from entering the middle ear and may protect the ear from bacteria or fungus in some way by trapping that in that gooey substance. This wax can either be wet or dry, it can be kind of sticky, or it can be grayish and flaky. When it becomes impacted, it creates pressure against the eardrum, and it makes it more difficult to hear. It can cause that tinnitus and some of those things like that. This condition actually is more common in older adults than younger people, but it can happen in some younger people as well. And most physicians are capable of being able to remove that. So there are some other risk factors for developing and having impacted earwax. The patient could have an abnormal ear canal shape, which will make it harder for that earwax to naturally exit. It could be associated with the disease processes that causes an increased production of earwax, or maybe even improper use of cotton swabs, which has pushed the earwax further into the ear canal than it should be. So symptoms of impacted earwax impaction include the sensation or pressure or fullness in the ears. They might have some dizziness because of that pressure. Really common for them to have some ringing in the ears or tinnitus, and maybe even some muffled hearing, a little bit of hearing loss. And they could even have some pain or itching in the ears as well. For us in the pre-hospital setting, what we're going to do is we're just going to get a good history from the patient and do a visual inspection, see what we can see of the ear. We might not be able to see a whole lot. The treatment goal for these are going to be to remove that excess earwax. So we're not going to attempt to do that in the field. But if it's not treated, it can lead to an infection and irritation that can cause further problems. So they should seek medical attention. I'm going to stop just shy of saying that we need to transport them to the hospital, but we should highly recommend that they seek medical attention. And if they want us to transport them, by all means we can do that. But it's not necessarily an emergency, an urgent situation that they need to take care of right away. So labyrinthitis often occurs after an ear infection or an upper respiratory infection. The irritation and swelling on the nerves of the inner ear can cause vertigo or loss of balance. It's a very troubling thing to have happen to you. They also may have some ringing in the ears, maybe some dizziness, loss of hearing, and even some nausea and vomiting that's associated with that vertigo and loss of balance. The pre-hospital treatment for them is the big thing that we need to try to do is to reduce the nausea and vomiting, because it's very discomforting to them. And of course, we're going to have to transport them in whatever position of comfort will work for them. Of course, with any of these, we want to make sure that anything really serious is ruled out. So they may require some more advanced imaging, such as a CT or an MRI, to kind of see what's going on in there and to treat it appropriately. So they definitely do need transported. When they get to the hospital, they're going to give them some antiemetics to control that nausea, or maintain the ones that we've started giving them. They may give them some antihistamines to reduce swelling. They may use some anti-vertigo medications that are available. And of course, they may just use Valium to sedate them a little bit to reduce the anxiety and cause some muscle relaxation as well. Meyer's disease is a chronic condition of the inner ear, and it's characterized by dizziness, low frequency hearing loss, tinnitus, and a feeling of fullness in the ears. Kind of what's believed to be going on here is it's an overproduction and defective absorption of it's overproduction and reabsorption of fluid in the ears that leads to increased pressure within the labyrinth of the inner ear. So realize there's that fluid that's on the inner ear. It overproduces it, or it's not able to reabsorb it. It doesn't clear out, and it builds up pressure within the inner ear. The distension can cause a rupture or a mixing of that endolymph and perilymph fluids. This mixing will disrupt the balance of fluid and electrolytes within the labyrinth of the ear and damage the vestibular and cochlear hair cells. So basically what's going to happen is eventually we're going to have a rupture. The two fluids that should mix wind up mixing, and it damages the cochlear hair cells that are responsible for hearing. So in the early stages, attacks last less than 2 hours, and balance is disrupted for up to a couple of days. As the disease progresses, symptoms can last for days. Permanent tinnitus, moderate to severe hearing loss, and chronic unsteadiness may develop. It's not a pleasant disease. So our focus for taking care of someone with Meyer's disease is primarily treating the nausea and vomiting by administering antiemetics. In the hospital setting, they may give some diuretics, of course, continue the antiemetic therapy, and even use some sedatives to help manage the symptoms of vertigo. Otitis interna and media are infections that results from bacterial growth in the inner ear canal, or in the ear canal. Otitis externa is an infection of the outer ear canal, often referred to as swimmer's ear. Otitis media is an infection of the middle ear caused by fluid buildup behind the eardrum. These are both more common in children than adults, and they're most commonly caused by bacterial infections. Otitis externa can be caused by an allergic reaction or a fungal infection, especially where moisture's been trapped in the ear canal. Otitis media is often caused by viral infections, especially following an upper respiratory infection. And otitis media is the one that we'll typically can see some balance disturbances with that one as well. So these usually present with with pain, such as a sharp or throbbing pain, and it can be worse with movement of the ear or the jaw. Itching is pretty common, especially with otitis externa, particular when there is an irritation or a fungal infection present. There may be some swelling or redness to the ear canal or the outer ear, and a diminished hearing acuity because of that fluid buildup and inflammation within the ear. There may be an inflamed or bulging tympanic membrane on exam with an otoscope. Otitis media, you may see a red or swollen eardrum, sometimes with pus or fluid behind it. So that explains the issue that they're having and the discomfort they're having. So what we're going to do for them, there's not a lot we can do. We're going to keep an eye on the symptoms and watch for any changes in severity, or if any new signs of infection begin to show up. We may need to administer some pain medication. Mild analgesics such as ibuprofen or acetaminophen are typically helpful with these and can manage most of the pain most of the time. Avoid using any kind of eardrops without medical guidance, as this may actually worsen the condition, especially when it's otitis media, or they may not be suitable for cases of patients with a ruptured eardrum. All right, the nose. Let's get nosy. The nose is very susceptible to injury due to its prominence on the face. The nose plays a critical role in respiratory health by acting as a filter, a humidifier, and a heater for the air that enters the body. It helps condition the air before it travels into the lungs, ensuring that particles such as dust and other pathogens are filtered out and that the air is the right temperature and moisture level. Of course, allergies and particles and chemicals can irritate the nasal passages and lead to inflammation or even infection. There can be some other complications from nasal disorders that are pretty common, as the conditions can spread to other areas such as the sinuses or even the respiratory tract. Many symptoms start as nasal infections such as rhinitis or sinusitis, which may be caused by a virus, a bacterial, or even some environmental factors. The inside of the nose is highly vascular and has a rich blood supply of vessels. Of course, this vascularity provides an excellent route for the administration of certain medications because the nose can absorb substances quickly into the bloodstream. But the downside to this is that same vascularity makes the nose more prone to bleeding when irritated or injured. Also, the nasal mucosa offers a short route to the brain, which is why nasal delivery of some medications like nasal sprays or drugs can have fast effects on the brain, such as for pain management or for decongestion. A loss of smelling or sensation can be caused by many factors. Aging is one of them. Smoking, allergies, rhinitis, nasal polyps, flu, COVID-19, medications, and traumatic brain injuries can all result in the loss of the sensation of smell. There are also some common smelling disorders. We have anosmia. I don't even know if I can say it. I'm getting all the hard words, guys. You got to give me a break here. Anosmia, and some of you guys are out there going, these are so easy to pronounce. Well, trade me places. The total loss of smell. Dysnosmia, of course, disordered sense of smell. It just sounds so weird, these words. This hyperosmia is an increased sensitivity to smells, and hyposmia, a decreased sense of smell, and presbyosmia. Hey, I started out saying these, trying to pronounce them, and I wasn't going to quit until I got through them. Is the reduced sense of smell due to the normal aging process. Now, I bet none of you probably got anything from this because you're probably too busy laughing at how my terrible inability to pronounce these words. All right, so a quick review of the nose. Of course, the nose is one of two primary entry points for oxygen in the body. As mentioned before, it warms and humidifies the air that enters the body, so it provides a vital role in protection. It contains some bony structures, and of course it's connected with sinuses, and those sinuses are part of how that whole filtration and warming process works. So when performing a patient assessment, look for those environmental clues that may lead us to a nose or sinus issue. Of course, make sure safety is key. Look at the airway and make sure breathing is sufficient, and determine what the patient's level of distress is. Because of the vascular nature of the sinus cavities, they are very susceptible to bleeding. And this is the typical reason why we're going to get calls in the pre-hospital setting. It's typically going to have to do with some bleeding disorder. Of course, you should insert any airway adjuncts as needed, but don't insert a nasopharyngeal airway or attempt nasotracheal intubation in any patient that we suspect has a nasal fracture, that has blood or what we think may be cerebral spinal fluid leaking from the nose. Inquire about a previous history of nose conditions or bleeding, and always consider a hypertensive crisis in an older patient when they have a nosebleed. All right, so the nose have it. Well, that's the end of part 1 for this chapter. We will pick back up in the next section with, I'm trying to remember, well, it's mostly upper airway stuff in the next section. We'll pick back up there where we leave off here.